move to the next slide. I'll welcome everyone to Family Medicine Grand Rounds. Today is February 10th, 2021. And of course, our event ID is 41047. We give you essentially several different ways that you can kind of log in to get some CME. So we hope that you do call in or use your computer, whatever that ends up being. Next slide. Of course, thank you to everyone for muting your microphones once the presentation begins. We don't want to have to mute you. Also, just being attentive to the presenter and, of course, being engaged. Dr. Buck, usually we will have people either put questions in the chat box or if the presentation allows it, sometimes we will also ask people to just ask the questions during the presentation. So I'll let you decide what you would prefer. And then, of course, I'm sorry, you were interested?
I think it would be good to put it in the chat, and then if you feel like it is of use, interrupt and say something. Given the challenge with the video, if there's one short 1-minute video, if the audio is not there, please tell me.
Okay.
So feel free to interrupt anytime.
And then, of course, we ask for people to please complete a session evaluation. This is important not only to the presenter, but also to just Grand Rounds in general, and it's also a CME requirement. Of course, we do have an educational partner, which is our South Central Area AHEC. So we always like to mention that they are involved in our South Texas Regional Family Medicine Grand Rounds. Next slide. Of course, you can always obtain CME transcripts through our internal UTESCA office. Next slide, as well as the AAFP, which is part of our CME network. If you have any questions, please reach out to Nicole or I. And next slide. Dr. Buck has no relevant financial interest to disclose. I will say that Dr. Buck is actually a really good example of referral from another provider. Dr. Obaid had actually mentioned having seen or having seen a presentation by Dr. Buck, and then reached out and said, hey, is there any way that we can get this person to come and present for us? So thank you, Dr. Buck, for allowing us to see your presentation today, but also thank Dr. Obaid for giving a good referral. I'm so glad that this worked out. So next slide. And I will pass it over to Dr. Buck. He will be presenting today why improving health, not just medical care, is so important and how do we start. Thank you, sir.
Great. Well, thank you all. And I wish that I could see you in person. Today, we'll talk about issues related to social determinants of health seen through the lens of homeless healthcare, where I had the privilege of working with Dr. Obaid too many years ago now. So our objectives is to understand how social determinants, which is a rather nebulous term in terms of how we can impact it, what are actionable social determinants, how they converge into a social gradient, what is one of the most critical social determinants, what the impact is from poverty, and how poverty has multimodal challenges, and what are some new care models from behavioral and cognitive neuroscience, as well as economic neuroscience, and then implications for system change. So this is in the context of a new medical school, the third medical school in Houston. And we're going to focus today on two of the missions of the College of Medicine: the conducting interdisciplinary research to find innovative solutions to problems in health and healthcare, and then engaging, collaborating with, and empowering patient populations and community partners to improve health. So this first is a story from a patient, Mr. Ed Friend. Perhaps the most frequent comment I get from my work with the homeless is that the homeless are on the streets because they want to be. I would like to share with you Mr. Ed Friend's story, a patient, a teacher who maintained he was on the streets because he wanted to be. About 15 years ago in the winter, I was asked to see Mr. Friend. He was living in an abandoned parking lot, frail, short of breath with a fever. He appeared clinically to have a pneumonia. He refused to go to the hospital, said he'd rather be dead than go to the hospital. I returned later that evening with an appropriate antibiotic and gave him my phone number, promising to see him over the weekend. A year later, he called me in the winter, again with fever and cough. I came out about 11 that night after my shift at the hospital, after your family docs. I'm a family doctor, so it was after a delivery, an OB delivery. Well, he was furious. Why would I come out here in the middle of the night? You should be home with your family. I shared that I'd been divorced in the prior year, and this was easier for me. Well, that visit changed our relationship. Hearing about my divorce, something changed in him. He saw me as a person who makes mistakes and has his own struggles. I think he could identify with me. I'm rarely asked to share anything about my life with patients, and rarely is it therapeutic to do so, but felt differently that evening by his outrage. That night, he shared with me the event occurring over 30 years earlier while living in a home with his wife and daughter when he had a $50,000 a year construction manager job. He shared that in a drunken state, he struck his wife and she stormed off in a car with their infant. She, also drunk, hit a tree, killing them both. He declared he would never allow himself to live indoors again, period. He felt he deserved a long, painful death for setting off an event that led to their death. He died the following year from liver failure and finally heart failure. For Mr. Friend, no home could accommodate his grief. It is a privilege to have known him. So frequently we don't have the privilege to learn the deeper stories, making understanding and compassion accessible to us. So I bet many, if not most of you, are familiar with the fact that most of the impact in health is not from medical care, or 20% here is what's known, but about 80% occur outside of the medical domain. You've probably seen these social determinants, which are usually 4 or 5 clusters. We've embellished it a bit here as we look at the major categories of chronic health disease, illiteracy, chronic unemployment, poverty, incarceration, food insecurity, homelessness and housing insecurity, untreated and unrecognized trauma, substance and mental health disorders. And here's a short 1-minute video clip.
I'm not hearing a sound, Dr. Buck.
That's what I understand. I'm so sorry. I'm going to try one more time to see if I can optimize that. And if I can't, I'll cover it.
Really easily. If you're living in poverty, you've got
Can you hear
separate the
now?
social determinants of mental health
Yes,
from the
we're good
social
now.
determinants of health.
we're all affected by the social determinants. The big differential is where we are on a social gradient. If you're not in poverty, you've got good education, you live in a nice area, exactly as Ruth was saying, you can push the stone relatively easily. If you're living in poverty, you've got limited access to education, you're living in very challenging housing conditions, that stone is almost crushing you.
Lots of people had tried to understand what is it that leads to inequities, what is it that leads to disparities, but actually the social determinants of health and the social determinants of mental health are most responsible.
The only way me and Sandy were able to connect was in that space of empathy. right? Because you have to understand when somebody coming from the community and we blend with the world of academia, that is a healing space for both sides of the aisle.
Can you see that?
Yes, sir.
Okay, whoops. Sorry. Technical difficulties abound. Here we go. Okay. Ugh. Can you see that? Meeting human needs.
Yes.
So if the major determinants of health are social, why aren't our remedies focused on that? And I'll give some examples of how widely disparate evidence shows that it is largely missing. We don't address the social needs. Treating disease while also addressing social determinants is critical. So you all may have been well versed in this, but I saw this from a video over the weekend that was shared about the difference between inequality, equality, equity, where you can see the two have different size ladders depending on different needs, and then justice, how there are many approaches to accessing what's equitable and fair for all. So what's broken in Texas? Since I'm in Houston, and we have the highest maternal mortality rate in Texas in the country, but in Houston we have the highest maternal mortality rate in the developed world. So as you can see, in the third ward, which is right where our medical school is, we have among the highest in the developed world. So let's start to dive in a bit about what are these social determinants and how are they impacting our population. These are maps of Houston, and it's the same vantage point. So you'll see it again and again, and you'll see in this a reverse C. You see here a high particulate matter that's ultimately realizing a high asthma rate. And if you look at, can you see my cursor? There's a triangle portion at the top right and a triangle portion moving middle to bottom left. Those are the predominant area for African Americans. And you'll see that again and again. So what can we conclude? Where you matter, where you live matters. The rates of pneumonia, asthma, chronic disease are very much associated with socioeconomic status and race. So another example, looking at can you hear me?
Now I can.
Hello? Okay. Life expectancy varies in Houston as many as 24 years from one part of town to another. One is a rail yard that has contamination that's resulted in increased cancer rates. The other is more largely rural area with a country club. So zip code is more important than genetic code. So here in a map of Houston, as you can see, there's been redlining that's been resulting in the maintenance of African Americans in particular with very limited access to housing assistance. And in these areas, you can see that these red line districts made it undesirable for lenders. So loans didn't happen. And if If you didn't invest your money in your house, the single largest investment Americans make, then you're less likely to have money to pass on to your progeny. Here, as you can see, these areas of high African American population, you can see how it mirrors out in the incidence of chronic disease, this reverse C and a low life expectancy that goes along with it. Here's an ethnic distribution where you can see that kind of emerging upper right triangle, and then the lower right triangle with a black majority. But if you fuse orange and red, you see this reverse C a little better. So if we look along around the world, not just in Houston, we can see a life expectancy variation of more than 48 years. The inequalities around this variation reflect social factors, and the social determinants impact all illnesses, and health impact should be assessed in all policy decisions, not volume, which is a frequent output measure of many of the health programs, but rather health impact. Well, looking at health impact, you see that the United States varies and has started to emerge away from the pack of their European. And then here from the Equity Trust in a book called Spirit Level, you can see that health and social problems, and we'll see in another figure that whether it's life expectancy, literacy, mortality, homicide, imprisonment, teenage births, trust, obesity, mental illness, social mobility, every one of these are made worse by greater disparity in income. And so we'll look at this a step further. In every measure, except for the social mobility index, you see all of these reds are the United States, and the UK is the one pink one. Well, we're not far from the UK in terms of poor outcomes related to social mobility, but they're a hair ahead of us. But you can see that we're in last place in every one of these, whether it's inequality ranking, we're the worst, mobility, life expectancy, teenage pregnancy, obesity, overweight, infant mortality, murder rate, prison population, voting rates, trust. So you can begin to see that our response tends to medicalize the social ills rather than address them. This is a severe example of what has turned into the same old results, which the results in COVID-19 death rates, you see a 10-fold greater risk of death, but this curve has started to drop. This shows a 10-fold risk. In the earlier deaths, they were much more likely to be deaths due to people of color. Now that's dropping a little bit, but it's still at least double in every city in the US. So Frederick Douglass said, where justice is denied, where poverty is enforced, where ignorance prevails, where any one class is made to feel that society is an organized conspiracy to oppress, rob, and degrade them, neither persons nor property will be safe. So none of us are safe if some of us are unsafe or living unjust lives. So let's now shift and look at, well, obviously poverty is a brutal force, but how does it impact the lives of each person we serve? Well, looking from the cognitive neuroscience literature as well as economic neuroscience, is a process called tunneling, that people that are living with competing priorities, where their survival is at jeopardy, they have the flexible intelligence and executive control is diminished to the extent that it results in 14 IQ points reduced in both an Indian study as well as a New Jersey study from the book Scarcity. So how can we shift from this firefighting trap where all we're doing is fighting fires and not looking long term? Well, first we need to look at what are some of the best practices. And the best practices show we should be managing the right scarce resource. And I'll show you shortly an example of an electronic health record that does just this. Through values-based care, it focuses on who and what is most important to you rather than focus on problems. And it focuses through coordination, through peer support, through technology that leverages data to assist with more effective decision making. So this is a little abstract, so let's reduce it to something tangible. Let's look at two students, Felix and Oscar. Felix is very busy, but he's relaxed. He turns in his assignments on time. Oscar, crunched for time, has the same course load as Felix, but he works more hours. He's always behind. He's working harder, trying to catch up, hard to follow the class content because he's behind and he doesn't understand the material, so he has to backtrack. He works harder, but for less. He's always a step behind. Well, let's look at it now. Felix and Oscar as farmers. Again, Felix is behind. Oscar is behind. Felix uses his savings to buy seed, fertilizer, and living expenses, while Oscar borrows money for the same ends. Both earn the same amount. Felix can invest in the next season, and Oscar has to use his investment to pay off the interest he owes. Oscar's always behind, experienced scarcity. He experienced really what is a misuse of the assets because it produces an effective shortage. So poverty results in poverty in terms of cash, but also bandwidth. That's this kind of firefighting mentality. So let's look at some new models. Engaging communities and individuals more effectively. What is this values-based care? Care coordination, a community information exchange, and informing policy with actionable data. First, I'd like to share with you how broken our system is. Because if we know that if we can provide access to SNAP, which is a food assistance program in Texas called Supplemental Nutrition Assistance Program. And it's a barrier system. You have to apply for it. In 3 to 6 months, you have to reapply for it. So again, it's like Felix, you're always one step behind, always applying for the next need to be met. But giving access to these benefits results in decreased costs. So including the cost of the SNAP program, it is cheaper when if every eligible senior was enrolled, we would be saving money. So this is an example of how the social ills translate to medical ones, and we medicalize them. So what are we doing at the University of Houston College of Medicine? It's a new medical school that is focused on, among other things, primary care and addressing some of these social ills. We have a investment in the community through a community engagement strategy called Healthy Connections, or Conexiones Saludables, where we have these 2 community hubs, and we hope to have more, where you have working groups. And in these working groups, they are comprised of community leaders that identify problems they want solved and partner to solve them. They participate with us in a community-based participatory style research, but we also have 2 groups of 4 CHWs that work in households in what's called household-centered care, that includes interprofessional teams of nurses and social workers, along with College of Medicine students, to address some of these complex needs. So using community information exchange, which is like a community, it's like a community, an electronic health information exchange. This is a community-based exchange, which includes community-level social and also medical data. So this is a little rendition of what this Healthy Connections looks like, from the 3rd Ward Hub, the 3rd Ward Working Group, and then household-centered care in each of these hubs. Then we have each of the departments at the medical school: research, population health, biosciences, and behavioral health, each developing a community engagement strategy. We have the community health worker infrastructure that will be accommodating 1,000 households by the year 2024. And then we have community members paid as patient simulation experts. This is from our community health worker East End group, the East End Hub. So now, to give you a model of what we're looking at, it's this community health model where we're trying to shift the power in the community from the medical model to the individual. But it's not a break in power, it's really shifting and sharing of power from the healthcare system to the client system, where the healthcare system has clinic interprofessional teams, community health worker, whereas the client ecological system is based on them, their community, organization, interpersonal, and consumer activities. And what are the barriers and enablers that can allow this shift? Is in the 2 bottom boxes. So developing a new model with new interventions requires a co-production. It's not the academic center develops it and gets feedback, but really we're developing it together with the community in partnership. See, household-centered care was built on a community health worker initiative of a 160-hour certificate program. But given the evidence of peer support, we also have a peer support infrastructure that includes a psychologist that helps to encourage every member on our team to set goals based on our own values and to work towards those goals. So it's not just about the patient's goals and values, but it's a principle we apply to everyone. So a project we did back in Dr. Obaid's era at Healthcare for the Homeless Houston is we had a jail Inreach program that addressed some of the social barriers to health, because as soon as you get discharged from the hospital or jail, you lapse in your medication. And so this program allowed same-day appointment from discharge from jail and hospital, so that you could have continuity of care. This program resulted in a 62% reduction in rearrest rates. So how do we begin to solve this siloed system where you have a psychiatrist, you have a mental health team, but they don't have any connection to the broader primary care needs, and they have no connection to the housing needs, to the SNAP and TANF benefits, to the housing support infrastructure. So we know what doesn't work. This gentleman, Mr. J, in 1 year, but over a span of 30 years, he was spending about $500,000 a year on his visits to the county hospital, which knew nothing of his EMS transports, which knew nothing of his jail bookings, his Houston Recovery Center for Chronic Sobriety, or chronic inebriation, rather, and then 76 arrests. That's just in 1 year to a spend of almost $500,000. If we were helping him, it would be one thing, but our services have been continued to occur, but really haven't gotten him into housing until just this last year. So what we need to do is begin to, these silos of care, we need to integrate through shared data and communication. A nonprofit in Houston called Patient Care Intervention Center integrates these core values with the centrality of social determinants of health through values-based care and a data analytics approach for system coordination through these 3 different levels of data exchange. So when we integrate data through systemic coordination, we not only see interagency level utilization overlaps, but intra-agency overlaps, so that we can begin to see and stop referring if someone doesn't have insurance or access to underserved care resources, then first they need ID. But in order to get an ID, they need a birth certificate. In order to get a birth certificate, they have to have often a voter's registration card. So why are we sending them to all these places at the same time, just reinforcing failure? We can do it collectively. So if we look at the hospital district, which is the county health system, through this overlap, you can see that roughly 400,000 visits in the hospital system are from 827,000 visits. So 400,000 people are producing about 2 times each visits, but 295,000 people of those 400,000 only show up once in the system. So most of the recurrent visits are from a small handful of people. Just like the $3.5 trillion spent in America, 50% or $1.75 trillion are spent each year on 5% of the consumers. So this shows where in age distribution, where in the ER or hospital, and what the diagnoses are. But they're across another system, the EMS system. And here, 85,000 clients result in 250,000 ER visits, EMS transports. So it's roughly 3 visits per person. And again, most of those are from the same small group of people. And then if we look in the homeless management information system, 9,000 clients result in 1.4 million visits. And what we see is many of these visits are for the same thing, an ID. And so why do we keep sending hundreds of people for an ID when they each time are sent for the ID and have barely get the ID? Well, we need to help them with those barriers rather than just reinforce failure. This is then the food bank, and out of 3,000 food bank clients, there's responsible for 18,000 visits. So how can we make food more accessible to people? And given the slide we saw earlier about SNAP benefits, how can we make it easier? So then values-based care is a model for vulnerable individuals that incorporate cognitive behavioral therapy and motivational interviewing, best practices for all people. It's focused on who and what is most important to you and what gets in the way. This is a patient we had, Mr. T, who struggled with homelessness, multiple ED visits and hospitalizations, and HIV and bipolar illness. In focusing on his dog, which is who was most important to him, we were able to get him into primary care, and he was able to sustain that continuity. So what is values-based care? Well, who or what is most important to the patient, Monica, in this example? Is it her son, a dog, a neighbor, food? What's the value? What is her aspiration? What does she like doing most? And barriers, what are the barriers to her accessing this? And can we track them and reinforce success? So we can do this through closed loop referrals with community partnerships and federated directories so anyone can participate. It's not you use our record system and we don't work with you at all. That's not going to be helpful in the long run. So in this model, agency one provides a service and or may need a service, and agency two has the same needs. But a referral is closed loop, then you document that the referral occurred, and it could occur across 300, 500, 600 agencies. This is the community resource exchange, which again is a federated model, meaning multiple different social service systems and medical systems could use it. This is the resource directory, which allows you to look up live time, what capacity there is in the system, where they're located, and do a referral live time. Then linking social and medical data, like we looked at earlier, can result in closed loop referrals and being able to allow the system change that we want to see. So I hope that you've the impact of this social gradient from the difficult to hear audio portion of the video of that rock falling down on the person, that steeper slope, the income inequality, that's the #1 measure of health, impacting health. The impact of poverty isn't just lack of financial resources, but bandwidth. And then some of the new care models that come from the behavioral and cognitive neurosciences. So now I'd like to entertain questions, and I wish, oh, here we go. I see some questions in this. Hi, Dr. Hein. I remember meeting you many years back.
Yes, David, it's good to see you, and thank you for a wonderful presentation. Looks like you guys are on the way to integrating some and doing some innovative work. So thank you so much for sharing with us.
Well, I'm sorry my video doesn't work, but at least I can see you all. I see a question by Dr. Obaid in the chat. What advice do you have for providers working in health systems that may not have the same values? I think that's to healthcare as the provider does. So what I do is I ask, and I frequently do this, particularly when I've had a miscommunication with someone. When we've gotten off to a bad start, I say, Oh my gosh, I'm so sorry. I think I didn't ask the right question. You know, what matters most is it's about you. Who and what is most important to you? And even though our electronic health record, where I'm at a clinic right now, you know, our clinic record isn't values based. I can still make note of that in the chart. And so so you can focus on values. It's hard to focus on goals when you have to build it into each note, but I put it in the assessment and plan. This is the patient's value, goal, and what the barriers they're experiencing. And then long term, I hope that we'll all be able to share not just the medical record, but share the health record so that we can work together. Oh, how are your community health workers funded? Dr. Hepburn. Great question. One of the actually two of the charities are funding it, and you know, some small percentage of Texas state funds for the medical school funded. But we're working hard to find a model that is that produces results that results in decreased costs to the health system and decreased costs that the funder will be willing to pay for. The typical funder is the insured, a managed care organization, but it could also be the community health or what we have. It's not Tarrant County there. It's Bexar County, I think. It's would be equivalent to that. What was the path, Dr. Ferrer, what was the path at the community level to get the multi-stakeholder commitment to aligning across sectors and organizations? So I think this relates more to the community information exchange. Is that right, Dr. Ferrer? I'll answer that, and then you can interrupt me if that's wrong. What we did is basically over time develop pilots, deliver on those pilots, and that helped get people's buy-in. Now I think Patient Care Intervention Center is getting buy-in from large payers, such as, you know, from Anthem to Blue Cross to Community Health Choice to Humana. I think Humana is very big in the San Antonio community. Did I answer your question, or did I?
No, that was helpful. Sorry, I was muted before and couldn't unmute quickly enough, but thank you for the response.
Oh, sure. I commiserate with your technical prowess at the moment, since I can't show my video, get it to work to save my life. Do you guys have community health workers there that you work with?
Yes, Dr. Buck, one of the things I wanted to mention is the fact that we have a pretty robustly developed community health worker program working in a residency program, and we'll be happy to explore ways of collaborating and learning from what you're doing, but also having you learn from what we're doing. Dr. Carolina Gonzalez Schlenker is on, I believe and she may be able to give more details.
I would treasure that opportunity. We have 8 community health workers for 100 households, with the plan of building considerably to 1,000 households. So how to fund it is challenging, but based on new Medicare, Medicaid legislation, it might fund more of these social avenues, but still nothing tangible yet.
Hi, this is Carolina Gonzalez Schlenker, and thanks, Dr. Hein, for pointing at to our program. So yes, we also have 8 promotores, and we've been becoming more and more integrated with the care of our patients here at Robert B. Greene. I know Dan Price is being a good colleague. We had actually a conversation last week. And the focus of our program, which is called Nosotros, is on the methodology of trust building. So we have had a theoretical framework that has maintained the promotores focus on making meaning with the patients using our model, and I will be happy to share. I have shared with Dan he came to visit us in San Antonio a couple of years ago when he was starting the program with you guys there. So there is a lot more that happens on the interaction patient promoter and then promoter clinic. So we try to be that bridge of trust, and it is that trust building model that we have had some innovation on, but we have had good results too. And maybe Dr. Hank or Dr. Ferrer can expand on those outcomes. Thank you. Thank you for your talk.
Well, it sounds like we have a lot in common because Dan uses the PCIC values-based care to build that trust, and we're measuring the impact on trust building. So I would love to get together offline, as Dr. Hain intimated, to learn from you guys.
Absolutely.
Any other, how do you fund your program? May I ask? This is, maybe I shouldn't be asking you all these questions, but if appropriate, how do you all fund the 8 promotoras?
So we started with funds from a 1115 waiver from Medicaid back in about 2012. And then as that wound down, though, we were able to point in the same way that you were, we were able to point to cost savings in patients managed by promotores that got and kept the attention of managed care organization that is on the hook for our patients' costs. So it ends up being a very parallel situation of what you do.
Interesting. I'm intrigued to follow up more. We're trying to create models that test the sustainability of different approaches like that. So thank you so much. Any other questions or tips? Oh, Dr. Obaid wrote, what should residents who are graduating later this year be asking during their job interviews to ensure systems? Wow. Huh. That's a great question. I think asking about behavioral health. How does your, say you're applying to work at a federally qualified health center or community center or a program, to ask the question, what resources are there for behavioral health, and what efforts are being made to prevent and reduce the kind of burnout that is so common in these settings. I think, we're all in a family medicine framework on this call. And so I think that commitment to a population where the resources may not match the need is pervasive. And so to ask them how they cope, how they struggle to find balance. Dr. Hepburn said, with the current pandemic, do you plan to leverage community health workers to increase vaccine administration and hesitancy. Great question. You know, we're really struggling with this. And so we're using both the working groups in those two hubs, as well as the community health workers, to identify the vaccine hesitancy. And I have to say, you know, with some embarrassment, or maybe I should just accept it, but about half of our community health workers, when we first started having the conversation in April, said, oh, no way, I'm not going to get a vaccine. They just put this thing together in the last few months. You got to be crazy. And then over time have shifted, but they're the ones that tell us where the problems are, where the misunderstandings are, and the misinformation emerge from. So it's actually been very helpful. And our medical students are producing FAQs, which I'd be happy to share with you, that address just the issues that the CHWs and our community partners have identified. I'd also like to share with you, if I have a minute or two. I've been working on a project with this Patient Care Intervention Center. And interesting to me is that we've identified the greatest risks in COVID infection is a non-high school graduate that's over 25 is many times more likely to be infected with COVID-19. And another, not surprising, has to do with low income, that income is a protective effect. If you have a significant income, it's a significant protective effect, but at 200% of poverty and below, it's a significant contributor to infection. Any other thoughts or questions? Well, I recognize you all are probably have 2 minutes left for the bio break until your next patient, but really appreciate you taking the time and inviting me. And it's always a treat to reconnect with my colleague, Dr. Obaid, and all of you. I've seen and worked with Dr. Ferrer and Carlos and others over the years. So wonderful to see you all.
Thank you so much, Dr. Buck. We really appreciate your presentation, the wonderful discussion. So thank you as well for presenting to us today.
Thank you.